Good morning, everyone. Thank you for inviting me here today to speak. So my name's John. I'm an advanced paramedic practitioner. As you can see up on the board, there's two job titles up there. So I've put that there specifically because advanced paramedic practitioner is actually quite in its infancy. And actually, the qualification that we do is the advanced clinical practice module in university. So we sit at the same sort of standard as our physio, our nursing, and our pharmacist colleagues. I'm also an independent prescriber as well, that I've done 2 years ago. So just a very quick look at my background. So I left school at 16, a handful of GCSEs, and joined the British Army. Turned out that I don't like being shouted at very much, and I don't actually like being told what to do, so I left quite quickly. I joined the ambulance service in 2004, and actually it's the best thing that ever happened to me, really. From having 5 GCSEs, I managed to qualify as a paramedic in 2009. And then in 2017, realised I needed to start my higher education. And that was quite a steep learning curve. That was all funded from HEIW, and all my education from my BSc has been funded by them as well. I thought it was important to spend some time as a paramedic and actually becoming a very good paramedic before I moved on to becoming a trainee and then obviously an advanced practitioner. So my current role, I've got quite a unique role at the moment with the ambulance service. I do 50-50. So it's a rotational model that the ambulance service has introduced. So I spend 50% of my time working for the ambulance service, and that's responding to our lower acuity calls that have come through on the 999 system. And then 2 days a week, I also work in primary care. So I work in a GP surgery in Barry, and that equates to 2 days in primary care and 2 days a week for WAST. The reason this has happened is because the increase of 999 calls, that isn't just accident and emergency anymore. We're finding ourselves dealing with more and more primary care complaints. And actually, we've identified that we need to deal with those as an ambulance service rather than batting them to other healthcare professionals. By working in the GP surgery, it does a few things straight away. It expands our knowledge on primary care conditions. It expands our knowledge on patient assessment. And actually, embarrassingly, I actually realised what GPs actually do. And being there, I didn't realise the workload that they're under. And actually, the level of care that GPs can provide to our patients and the referral pathway to our secondary care providers. It was a very steep learning curve for me. And when I'm in the GP surgery, I have 15-minute appointments. So on an average day, I'm dealing with between sort of 25 and 26 undifferentiated patients. And as a whole, between me and my colleague, we're doing 100 patients a week in that GP surgery, which is taking the pressure off the other GPs. And hopefully it's going to allow the GPs to spend that time dealing with the complicated medical patients that they need to be spending time with. I think for me, from moving from a paramedic to a trainee advanced practitioner and now working at an advanced level, I think for me, the onus is I'm not just treating patients. So it's very easy to go out to somebody with a chest infection, give them the antibiotic and, move away. I think working at the advanced level that I do, it is about managing that patient, and it's about implementing a care pathway. And it's about understanding that actually that chest infection is stemmed from their COPD, their asthma, or their industrial lung disease. And it's about making sure that we manage the patient throughout their sort of period of being unwell. I think my role specifically in the GP surgery is dealing with the minor injuries and minor illnesses. And actually, what we now do is dealing with some of the longer term conditions as well. So it's about dealing with patients with hypertension, asthma, COPD. It's about seeing the patients that, have heart failure. It's about arranging the right diagnostic tests for them, and it's about arranging the imaging for them as well. I think what has been very, very reassuring is actually when you're working in the GP surgery and you need to refer patients to secondary care, actually every time I've done that, it has been welcomed. And I think that's very, very reassuring. When I work the other side, and I work for WAST, what I'm able to do is draw that knowledge from the GP surgery, and that comes out on the road with me. So whereas before I could be on scene with a patient for 45 minutes to an hour, and it would be, my paperwork would be no chest pain, no shortness of breath. We were very good at telling people what wasn't wrong with the patient, and actually our area that we were saying what was wrong was actually quite small. And I've now swapped that round, and actually I think at an advanced level practice, the onus is on what's wrong with the patient, not what isn't wrong with the patient. And that has reduced my scene time. So I can be on scene for 15, 20 minutes now. So it's essentially working the GP surgery, but actually out on the road, responding for Welsh Ambulance Service. I think by working the GP surgery, what it has done is built up better relationships with other GP practices in the local area. And there's a much better referral pathway that I'm able to do and speak to the GPs and refer the patients directly to them. And they're very, very sort of receptive. And I think as key, we're also there to make complicated decisions as well. So any of our colleagues having any best interest decisions or complicated medical patients, then we can be called upon to go and help them and just assist them with their decision making. And very often what it is not about making the decision for them, it's just about supporting them, because actually they've made the right decision. It's just about reinforcing that decision making for them. So as an independent prescriber, I would say it's not essential to be an independent prescriber in primary care, but what it does do is it makes life an awful lot easier. So prior to being a prescriber, what we would have is hot reviews. So we'd have a hot review after our morning clinic and then a hot review at our end of our afternoon clinic. The downside to that, it meant that the patients were having to come back to the surgery to pick up their prescriptions. So it wasn't ideal for the patients. But what it did do is it allowed me to have that education, because I was going into the GPs, I was suggesting, actually, I think this patient needs X, Y, Z, and the GPs would say, oh, that's fair, but however, have you thought about this option? So during my education as a prescriber, that was really, really essential. I think where we went from a novice prescriber to now I'm a sort of competent prescriber, it also allows our patients to have a better sort of journey, if you like. Very often they'll come into the surgery with a chest infection. We do an assessment, we do their blood pressure, and actually what we found is actually they're good incidental finding, they're really hypertensive. And then having that independent prescribing qualification, it allows you to manage that condition as well. So it's about putting in that care pathway for their hypertension. So it's about giving them the workup, ordering the right bloods, ordering an ECG, and looking at their lifestyle changes and implementing lifestyle choices and empowering them to make changes for their own health. So why do we need APPs and independent prescribers in the ambulance service? So I'm quite sure many of you have seen this slide before. But on the left, you'll see at the moment we're we're dealing with 10% of patients over the telephone. Our see and treat is about 30%, where we're able to go out and see people. But we're actually transporting 80% of our patients to hospital. And what we need to do is we need to swap that around. It's just not going to work. We've got an aging population, and with our aging population comes health conditions. We need to be treating these patients more in the community rather than just taking them to the accident and emergency departments. As advanced practitioners, the future is looking very good. So we're aiming to deal with 50% of our 999 calls over the telephone, and our APPs and our independent prescribers are going to be essential in this. And getting to the point that our advanced practitioners will be able to work in the control room, and they will be able to undertake remote telephone triage and assessment over the phone, and actually do remote prescribing. The other 30% where our APPs will be going out and they'll be doing face-to-face consultations, and that is going to hopefully be able to deal with them in the community. All of our APPs carry PGDs. So they'll be able to issue the PGDs, or our independent prescribers will be able to give them the medication that they require to stay at home. That said, there are a group of patients that have to go to hospital. That's absolutely the right place for them. It doesn't mean they need to go to the accident and emergency department. As our APPs, we're able to speak directly to the SDECs, able to speak to the med-regs and the specialities, and we're able to refer these patients directly to the specialities rather than clog up the accident and emergency department. What this should do in the future is it should free up our resources. So our emergency ambulances should be able to respond in a more timely manner to the patients that they need to be going to. Areas that we could improve on, I think we need, at the moment, minor things, fit notes. As a paramedic, I can't issue a fit note. Our nursing colleagues can, our physios can, our pharmacists can. But again, paramedics, we've just fallen outside the net on that kind of stuff. And that's why I've put in there about equality with our nursing and physio colleagues, because ultimately we're doing the same job, but there are little nuances that we could improve on. And I think the relationships with our secondary care providers, this is something that we can really improve on. It's something that we've noticed over the last sort of 2 years since we've been in the primary care. The relationships have started to really grow to the point now where we're speaking to the specialities and they recognise us. And actually, once they recognise you, you start to build that trust. And actually, the referrals are much easier than they used to be. Used to be quite challenging, but now it's much better. And happy to take any questions.
Thanks, Chris. Really enjoyed that. Really interesting and a really interesting model. Are there more of them?
There are. So in Cardiff and Vale, it's actually been up in North Wales for 3 or 4 years now. I think if you Google Pathfinder, there's a Pathfinder project set up to see the validity of it. In South Wales, advanced practitioners have been there for probably 9 or 10 years at least. However, hasn't really been championed. In the last 2 years, it's really been championed. I mean, we've gone from 2 advanced practitioners in Cardiff and Vale to 13.
And then that dual role?
Yep. So there's one practice in Barry, which is the Waterfront Medical Practice. Yeah, there's one practice in Barry, the Waterfront Medical Practice, that there's 2 of us working in there. We also have a cluster, the North Cardiff cluster, where we've got advanced practitioners with the North Cardiff cluster GPs. And I think there's a view to expand that to other GP surgeries in Cardiff and Vale.
It just seems such a good model for all the reasons you outlined. And I suppose my next question, and then I will stop, is what's your thoughts about where else it could be? Because you mentioned secondary care, and again, it struck me that having a dual role sitting across WAST and secondary care could be hugely beneficial.
Absolutely. I think, interestingly, if you look at some of the NHS job adverts, it's advanced nursing practitioners, and actually, is that word incorrect? I don't know. Should it be advanced clinical practitioner? Because I think as paramedics, there's a lot that we can bring to the party. We're one of the few professions that get invited into people's houses. And actually we see people in their own environments, and I think that can be key sometimes, especially our elderly and our frail patients. We see how these people are trying to live, and actually when we then try and refer to our occupational therapists, we can say on a house call, actually this patient needs your input. Their daily living is actually dangerous. They need an assessment. So I think our acute medical wards, I think APPs would really be beneficial, and our same-day emergency care units, our SDECs, I think that'd be really useful.
Just to add to the response, HIW, through our primary care work, we are looking, and there's an event coming up soon, and I haven't got the exact date, to look at advanced paramedic practitioners on their contribution. So we recognise exactly what you're saying.
Yeah.
So we are looking to facilitate improvement.
It's intermittent.
Thank you, John. Just a comment, really. I'm aware that I work in Velindre in a palliative care team, managing a group of ACPs, in palliative care and trainee ACPs. And I'm aware there's a very similar model with palliative care, with rotation in community. And very positive feedback from that from my community colleagues, certainly in Cardiff and Vale, Swansea Bay. And to me, I think we're growing a lot of our sort of nurse and therapies, ACPs within our organisation, particularly in acute oncology. And I think we also need to be thinking a little bit more about that rotation the other way and replicating that more widely, certainly not only with nursing, but I think with our AHP colleagues, maybe OT, physio, because sometimes people have an appointment to see somebody, but you need something in that moment. Through our treatment helpline and things like that, I think we can add quite a bit as well the other way. And as you say, generic job descriptions, it could be anybody with those kind of.
Exactly. I think our community treatment teams are, you know, we'd be ideal in our community treatment teams. So we've got our community treatment teams in St David's, and actually we could integrate into those really, really easily. Our district nursing teams, we could integrate with those very, very easily as well, because it would just work.
Yeah, so I think you've made a really valid point about the disparity between professions in ACP roles. You've mentioned FitNote, but the other side of that is also prescribing as well. Yes. So within the context of my acute frailty medical team, I have one paramedic and I have one physiotherapist working at the front door of the hospital. And whereas we can prescribe all drugs, anything in the BNF, they are slightly limited. I think controlled drugs they cannot prescribe, which actually does create barriers in practice. I think if we're looking at these roles very generically, from an advanced clinical practitioner point of view with that heading, then everybody needs to be doing the same thing. And I think this is something that we need to push forward and change for better practice.
Yeah, I didn't want to just stand up here and concentrate on the negatives. But the legislation is changing. So paramedic prescribers, it has gone through Parliament. It's just waiting for the T's to be crossed and the I's dotted. And that's going to allow advanced practitioners from paramedic background to use and prescribe morphine, midazolam, codeine-based medication, temazepam and lorazepam. There's still a few areas that they haven't gone into for whatever reasons, but I would like to think by this time next year it will change, and that does affect us in primary care as well, because you know a lot of our patients need good analgesia. You know, they need a codeine-based analgesia, and we were unable to do that. So again, I need a GP to sign it. Yeah.
It doesn't make sense that every individual colleague or just think that radiotherapy is the same. That's such a limited number of things that they can prescribe from, and in fact restricts them in a way. They can't think more widely because they're just, you know, constrained by these individual needs.
So realistically, from a legal point of view, you know, you can prescribe somebody rocuronium, but I can't give them cocodamol. So it's a bit silly. Thank you.
Sorry. One more question. So I'm Marie and I work in Powys. As you can imagine, your sort of role within the Powys community would be incredibly invaluable with primary care and also in West. Looking at the parity thing, I'm not sure whether people are aware that in England, they are looking at joint roles and joint registration career pathways. And that's something we're going to look at in Powys, about whether we can offer placements to people who are going through a nurse paramedic career pathway. So that would be really interesting to understand the differences and what that means when we actually start at registration level, about how we develop those new roles.
Yeah, I think it would be, I think, is it Birmingham they're doing that degree?
Edge Hill, yeah.
Yeah, I think it is, it's very interesting to do a dual qualified degree. I'm not sure there's any out at the moment, so it'd be interesting to see how that works in the system.
They start in September.
Do they?
So yeah.
Yeah, it'll be very interesting. I think it's going to be an exciting journey because they're going to be perfectly placed to move into advanced and enhanced practice roles.
Thank you very much.
Thank you.